This is Bob Leahy from PositiveLight.com, and we're in Montreal today. We're at the National Housing and HIV Summit in Montreal, and we've just had a presentation on various types of housing for people living with HIV. And with me this afternoon is Rosalind Baltzer-Turje, is that right?
Correct.
Okay, and you're from Vancouver, right?
Yes, I am.
You're visiting Montreal for the conference.
Yes.
And you just presented on the Dr. Peter you're representing the Dr. Peter AIDS Foundation today.
Yes, I am.
And you talked about the Dr. Peter residence, right?
Correct.
All right. Tell me, Rosalind, who was Dr. Peter, first of all?
Okay, Dr. Peter was a physician that, and his name is actually Dr. Peter Jepson Young, and he was a physician that in the 80s he not only came out as in terms of his AIDS, but also in terms of the gay community, in terms of his identification that way, and he also made a face because he was a physician as well. So he kind of put the face of AIDS in the 80s in Vancouver. Mm-hmm. And he did a series with CBC, which was called The Diaries. And he not only educated people on AIDS, also told about what he saw as the epidemic coming and what we need to do with that.
Right.
And his legacy actually was the Dr. Peter Center, or the Dr. Peter AIDS Foundation. Just prior to his death,
right,
the Dr. Peter AIDS Foundation was formed, and his legacy is the Dr. Peter Center.
Okay. And he was HIV positive himself?
Yes, he was.
And he died when?
1992.
Okay.
Yes.
So his legacy then is really the residence that you were talking about today.
Yes,
it's one of the legacies.
It's one of the legacies.
Yeah.
It's actually the whole center is his legacy.
Now, you have a housing facility for people living with HIV.
Correct.
Tell me what sets it apart, Rosalind, from other facilities which just provide housing. You provide a bit more, don't you?
We provide housing and care, and so it's 24-hour specialized nursing care, and it was designed specifically for people who are more challenged in terms of their health context and also with mental illness and active addiction.
Right.
And so all our services, and which is the residence is one of them, focus on that most vulnerable group. Right.
And I think you mentioned you particularly have a particular focus on harm reduction because you have a number of people with addictions. So
correct.
you provide, I think you mentioned, it was interesting to me, that you provided a safer injection. How does that work, the safer injection facility?
Okay, so
a supervised injection, I think you said. That's correct, isn't it?
Supervised injection
Yes.
is a service.
Yes.
In terms of, and it's under nursing care.
Right.
It's under practice guidelines for nurses. That is something that they can practice, they can provide. What it is, it's a strategy, one of the harm reduction strategies in terms of engaging people in their health care. We know that it is for actually promoting health, reducing illness and the spread of infection, and essentially it is teaching individuals and their understanding of how to prevent illness and the spread of infection. So it is safe injection in terms of sterile water, how to inject properly,
right,
looking for skin breakdowns and abscesses, what's safe use, when to use, to be with somebody, those kinds of more health-oriented aspects.
And that's provided by an on-site nurse. Is that 24 hours? Is that how it works? Or?
That's in the residence.
Right.
People that come into the residence many people that come in have an active addiction, and some are injection drug users. In order for us to engage people in healthcare, in order to properly give the whole services, we accept that they may have an active addiction, and rather than just say, okay, we accept it, we're not going to talk about it, we openly talk about it. It needs to be a conversation. One of those services, so within harm reduction for people that are drug use, it could be supplies that they have, and within supervised injection, it is instructing the person or having the supplies for that. And it could mean that a nurse supervises the injection. They have their own rooms, so it's within that context.
Within the room.
Correct. Okay.
And you'd also provide needle exchange, I imagine.
Correct.
Yeah. I can step back a little bit. Most people know this, but let's just step one back. Harm reduction. Particularly people in the US are less familiar with the concept and less bought in it. Tell me what your vision of harm reduction is, particularly in the context of what you do.
So the harm reduction from our approach is looking at the risks that are in that person's life and reducing that risk. So if you look at a person that injects drugs. If they are doing it unsafely or sharing needles, that would be an unsafe practice in that. Then that is a harm reduction. We're intervening in that risk to reduce that risk.
Mm-hmm.
If it's that they're not eating well, we provide nutritious food and we provide the high caloric in order to be able to reduce that risk.
Mm-hmm.
A safe place to live reduces the
Now,
risk.
I'll ask you this. How does that facility fit into the surrounding community? Have you had, is it accepted by neighbors? Are there any issues there? Or?
We've been very fortunate because we were very supported in not only the vision in terms of creating the foundation and creating the center, and we are near a hospital as well. We are in the community in the West End. We are very accepted, and
you're near the
we're in St. Paul's Hospital, and that's
right.
right. And we're in the West End community, and so that in terms of the demographics in the West End is part of that gay community. Is there we're very accepted. We're a risk community. We also one part of the community is that we have an elementary school nearby. We have childcare nearby. We have shops nearby. So it's yes, we have been very supported and welcomed.
Okay, and so you're integrated within that community as well.
Yes, we are.
That's good. Tell me a little bit about the people who typically you house. Now, some of them are more permanent residents than others, but tell me what sort of issues they come to you with.
Okay, so we provide services for adults. They're all adults, so it'd be 19 and older. It is majorly men. We're open to men and women, but we see more men entering our service.
All with HIV?
All with HIV, so that's kind of their common.
And some with co-infection, I imagine?
Yes, there's a high incidence of co-infection in terms of, particularly what we're seeing is chronic obstructive pulmonary disease, the hepatitis C virus, the diabetes and cardiac incidence of that as well. So they come from the community and it could be referred from the community.
So some of them may have come off the streets and with a complexity of issues.
There are what we found in our population, about 55% that are now in our residence have been homeless in their life.
So they can come
prior to coming into the residence, they were homeless, and then they had a history of homelessness as well.
So they have multiple issues, and you try and sort those out.
Yes, we see the person in their whole and what they are, and in terms of understanding, accepting that the trauma that has happened in their life through the homelessness, through the stigma, through the poverty, those kinds of issues in their life.
Yeah. Tell me, this is an interesting model. Does it work?
Yes, we think it does.
tell me why you think it works. Do you have research? I think you've researched.
Yes, we've started our research into that. We have looked at studies and we've seen that there is an increase in adherence. We have some quality of life that I was not able to present today, but the quality of life shows a satisfaction, higher satisfaction. We do have people staying, which is a indicator that people feel accepted and that they and engaging in their health care, so that they are seeing their physician, following up on appointments.
Well, that makes me ask, are there limits? Can they stay forever, or is it transitional?
There are two programs. There's a long stay where people, if they're needing that 24-hour care, they stay. There are some people that are challenged to move out, but many people do move. Not unlike a lot of other facilities that would look at complex needs where they stay, people do come in and they can transition. It is their home for as long as they need that home environment.
And is it a nice home? What do the rooms look like?
We think it's a very nice home. It's we take a lot of pride in our environment and keep that and for the dignity, respecting the person in terms of what they need in their environment. They're like a small studio suite, and there's a full bathroom in there as well, to shower and toilet, and it's made so they can wheel into there or walk into its flat. A very European design. We provide care, so the room can be made into call bells and everything else for nurses, but when you first walk in, it actually can be designed in however they want. We provide the furnishings, the tables and chairs. There's a place for TV.
They don't have much anyway.
That's right. We provide that TV. We provide the internet. We provide a place for clothing and a place where they can keep some food or a small fridge and microwave.
I should check in and stay there.
That's right.
Just one more question. It's a very interesting model, Rosalind. You must get some satisfaction out of making a difference, changing people's lives. Is that something that you see on a day-to-day basis, that you really change lives around?
I'm changing people's lives. I think it's it's more not so much, yes, there's a context in terms of however that person is describing. I think what we're seeing is that when a person relaxes, when they trust,
that's important.
when they feel enough trust to be able to provide, to be part of their health care and to be able to talk to us, I think that's where
Right.
because it isn't so much about change. Certainly we hope that people will feel enough, will gain some knowledge, will understand what they need and be able to be active in their health care and be better that way. So I think in terms of improving their health and improving their health outcomes is probably, I suppose, the change that we're looking for.
That's good. Yeah. Rosalind, thank you so much for joining us.
Thank you.
Positive Light reporting from Montreal at the National Housing and HIV Summit.